Well, I'd like to take this opportunity to thank both the American Thoracic Society and Novartis for giving myself and my partner, John Bosso, an opportunity to talk to you about the pathophysiology and management of chronic rhinosinusitis with nasal polyps. I am a otorhinolaryngologist at the University of Pennsylvania, subspecializing in rhinology, and I run a basic science lab on upper airway respiratory innate immunity. My co-presenting partner is John Bosso. He is an allergist whose primary appointment is in the Division of Rhinology and works very, very closely with us in the management of our chronic rhinosinusitis patients. Our disclosures are as follows. Chronic rhinosinusitis is a syndrome which is the manifestation of chronic inflammation of the nose and the paranasal sinuses, characterized by a minimum of 4 signs: nasal blockage, obstruction, congestion, nasal discharge, mucopurulent drainage, facial pressure and pain, and reduction or loss of sense of smell and taste. To make the diagnosis of chronic rhinosinusitis, you need 2 or more of these signs and symptoms that have been in duration for 12 weeks or longer. Historically, chronic rhinosinusitis has been partitioned into 2 broad categories: without nasal polyps and with nasal polyps. And at the top of the slide, you can see a classic presentation of non-polypoid sinusitis, which is really an infectious process. You can see purulent drainage coming out of the maxillary sinus. On the CT scan, you see the classic air fluid levels. You see the inflamed bone with thickened osteotic bone. And it's predominantly a neutrophilic driven disease. On the flip side are the chronic rhinosinusitis with nasal polyps. These are protuberances out of the mucosa of the ethmoid cavity that basically fill up the nasal cavity. Classic radiographic findings in the middle panel with complete or near complete opacification of the paranasal sinuses. And up until very recently, it was felt that this was predominantly an eosinophilic driven disease. In our polyp patients, up to 60% of them will have concomitant asthma. And taking it the other way, 7% of asthmatic patients will have nasal polyps. Now, I suggested that some polyps are not eosinophilic, and the classic for that are polyps coming out of cystic fibrosis. While clinically they look like your classic garden variety polyps, histopathologically, they're mostly neutrophilic. And as research into nasal polyps was going global, we started noticing that polyps in Asia, specifically in China, well, again, they look like your classic eosinophilic polyp. On pathologic sectioning, they were predominantly neutrophilic. The signs and symptoms of these 2 broad categories, some are shared. For regard to chronic sinusitis without nasal polyps, it's predominantly facial pain and pressure, purulent discharge, and nasal obstruction. Whereas with chronic sinusitis with nasal polyps, while they share a lot of this, the predominant symptom is really reduction or loss of sense of smell and taste. They do complain of nasal obstruction, but it's not a big deal. They rarely complain of pain. As mentioned before, it is correlated with asthma and aspirin hypersensitivity. On the right here, I'm showing you severe nasal polyps, and you can see gross polyps coming out of this patient's nostrils. In the lower left is a nasal endoscopy showing a more discrete nasal polyp. This is one that's going down to the floor of the nose, but yet if you weren't looking with an endoscope, you wouldn't see it. And in the bottom right is the burden of polyps that we can remove from a patient's nose. So what are nasal polyps? These are non-cancerous grape-like lesions that are coming off the respiratory epithelium, predominantly out of the ethmoid cavity and protruding into the nasal cavity. They're often associated with allergy, as mentioned before, asthma. With infection or colonization, often we will culture out Staph aureus in these patients, but they're not grossly infected. They're also associated with fungal colonization, and as discussed before, with cystic fibrosis and aspirin sensitivity. Worldwide, the prevalence of chronic sinusitis with nasal polyps is roughly 4%. Of all chronic rhinosinusitis patients, somewhere between 1/4 and 1/3 of them will have polyps. The polyps tend to be more common in male, but more severe in females. And the age of onset is usually in the early 40s.
Comorbid conditions exist that impact the pathophysiology of CRS with nasal polyps. There are several of them, the two most common being asthma and allergic rhinitis. And so having these comorbidities can actually worsen the underlying burden of the CRS with nasal polyps. As Noam mentioned, up to 60% of patients with CRS with nasal polyps also have asthma. But when these two conditions are present together, they worsen each other. And so the presence of CRS with nasal polyps and comorbid asthma will worsen the control of asthma. It'll also result in increased lower airway inflammation as well as lower airway obstruction. On the flip side, the presence of asthma with CRS with nasal polyps will make those polyps more difficult to eradicate. They tend to recur more quickly, and these patients tend to have higher symptom scores for their rhinosinusitis. This lends credence to the unified airway disease theory, which basically states that the upper and lower airway are responding to a single inflammatory process throughout the entire respiratory tract. We are looking more deeply than phenotypes. We started out talking about CRS with or without nasal polyps as what you see. But we really want to get to the underlying inflammatory mechanisms. And so now we're starting to talk about endotypes, which are really based on molecular mechanisms. And so there are three major types of inflammation. But 85% of nasal polyps are characterized by type 2 or Th2 mediated inflammation, which actually worsen the disease severity, portend more recurrence, and also have a higher risk of developing asthma. Type 1 and type 3 inflammation is more neutrophilic or purulent type inflammation. But type 2 inflammation is what we're going to speak mostly about today, and the key cytokines being IL-4, IL-5, and IL-13. But also this is more of an eosinophilic inflammatory response and often is accompanied by the release of cysteinoleukotrienes and prostaglandins. Another way to look at endotypes is to look at T2 high inflammation versus T2 low inflammation. And so with T2 high, you obviously have a predominance of T2 cytokines. And examples would include atopic or eosinophilic asthma, as well as eosinophilic CRS with nasal polyps, and one subtype, which is called allergic fungal rhinosinusitis. On the flip side, T2 low asthma is a non-type 2 or a low in type 2 cytokine type inflammatory response, and much but not all of CRS without nasal polyps falls into the T2 low category. Again, these are not hard and fast dichotomous breakdowns because there's a lot of overlap between the two types. Non-eosinophilic CRS with nasal polyps, for example, cystic fibrosis, would fall into the T2 low category. You can see that the mediators are different. Gamma interferon, IL-17, and IL-8 are the most predominant cytokines present in T2 low inflammation. Let's delve into the type 2 mediated inflammatory cascade and CRS with nasal polyps in a little bit more detail. You have an epithelial barrier that is basically intact unless it is broken down and breached by various factors such as bacteria, allergens, viruses, proteases, parasites, or even toxins. And once that barrier is breached, there are certain epithelial cytokines that we call alarmins, which include TSLP, IL-33, and IL-25, which then sound the alarm to mediators such as dendritic cells, ILC2 cells, and mast cells, to then stimulate the adaptive immune response, resulting in the release of type 2 cytokines. Dendritic cells will present antigen to Th2 cells to stimulate the release of IgE antibody from B cells and plasma cells. ILC2 cells will feed forward onto the type 2 cytokines, which are then released, and mast cells will release factors such as leukotrienes and prostaglandins, which will bind to ILC2 cells through specific receptors, then again promoting the release of type 2 cytokines, which are IL-4, 5, and 13. IL-4 notably will stimulate the production of IgE antibody. IL-13 is responsible for cellular recruitment, excessive production of mucus, but also the deposition of fibrin, which leads to remodeling. IL-5 will stimulate the proliferation and survival of eosinophils. Solitary chemosensory cells are a specialized cell in the epithelium that also bridge the innate and adaptive immune response. These specialized cells have taste receptors that sense not just stimuli, such as quorum sensing molecules from bacteria, and they release into the lumen antimicrobial peptides. But more importantly, what they do is they stimulate neurogenic inflammation by stimulating sensory neurons to release neuropeptides. Directly, they release IL-25. They're the primary source of IL-25. And both of those will stimulate the innate lymphoid type 2 cell to release IL-13, which will feed back in a positive feedback loop towards the solitary chemosensory cell to produce more IL-25. In addition, the ILC2 cell is responsible for releasing IL-5, which we know stimulates the production of eosinophils. In the lower airway, interestingly, solitary chemosensory cells have been shown to migrate there following influenza infection and releasing IL-25. And this potentially could be the link between respiratory viral infections and asthma. Staphylococcus aureus, as alluded to before, plays a role in the pathophysiology of CRS with nasal polyps. About 2/3 of patients with CRS with nasal polyps are colonized by Staph aureus, as opposed to about 1/3 patients without nasal polyps. And Staph aureus will produce enterotoxins, which break down that epithelium, damage the barrier, and act as superantigens to produce a Th2 or type 2 inflammatory response. And this will release various cytokines, as mentioned in the prior slide, that will then enter into the polyp to cause inflammatory milieu to be enhanced. In order to understand the role of the eosinophils in nasal polyps, I wanted to demonstrate these two pictures. On the left is a polyp that is very, very chock full of eosinophils, 800 per high-powered field. And on the right, you see a polyp that has been depleted of eosinophils with an agent that depletes eosinophils. And what you see is that there is no change in the size of the polyp. Remodeling has already occurred, and other inflammatory and immune cells are active in the polyp, showing that the eosinophil alone is really not what drives nasal polyps.
So we're going to go through a simple model of how these polyps are forming. And at baseline, the nasal epithelium is not sterile. It is certainly colonized, and that's very, very important because there's a tonic stimulation of both the innate and adaptive immune systems in the upper airway. And this is a chance for the immune system to truly sample what the threats are for the respiratory system. And so what you see here is a low level of inflammatory cells. There's dendritic cells, and there's the predominant form of innate immunity, which is mucociliary clearance. Some mucus glands are making mucus. The bacteria, the microbes are being trapped in it, and the cilia are sweeping it away. If there is a dysbiosis, or if there is an injury to the epithelium with a breach in the epithelial barrier, you get a stimulation and you get an exuberant inflammatory response, both through innate and adaptive immunity, resulting in more immune cells migrating into that area of the dysbiosis or breach in the epithelial barrier. This then turns into a self-propelling vicious cycle of inflammation with more inflammatory cells, and then, as John mentioned, deposition of cross-linked fibrin. And you got to remember that in the nasal cavity, the underlying structure is bone. So as this inflammation continues, it's going to follow the path of leaf egress, which is going to be basically into the nasal airway. And so there's edema, there's this fibrin deposition, and as the lamina propria is breached, this then outpouches into the nasal cavity as a formal polyp that has tissue remodeling and there's loss of these submucous glands, and there's varying degrees of the fibrous component, but there's this massive inflammatory infiltrate in this lined epithelial bag that we call a nasal polyp. So for diagnosing nasal endoscopy, in the specialist hands, we use nasal endoscopes, and this is the preferred method by multiple societies in ENT. And it allows more for than just a superficial surveillance of the nasal cavity. It allows us to get deep into the nose to assess the middle meatus and the superior meatus, to look for any purulent secretions. If there are purulent secretions, we can often identify which sinus are coming out of. And more importantly, is we can do endoscopic guided cultures, so we can get a very, very clean sampling of the infection for antibiotic treatment. It also gives us an opportunity to determine the polyp burden. And so a scoring form was basically set up where no polyps are scored 0. Small polyps getting down to the level of the middle turbinate are scored 1. If they go below the inferior margin of the middle turbinate, they're scored 2. To the level of the inferior turbinate, or if they're found medial, so between the middle turbinate and the septum in the olfactory groove, it would be graded as a 3. And if they're completely filling up the nasal cavity, it would be a 4. So this is used in both sides, and so patients can be scored anywhere from a 0 to 8. So when you're assessing therapeutic interventions and you see polyp score, this is what they're talking about. And so on the right, you can see a polyp actually emanating out of the olfactory groove between the middle turbinate and the nasal septum. In primary care, a nasal speculum can often be used to get a little bit beyond the nostril, but you're really only going to see grade 3 or grade 4 polyps. You're not going to see the more subtle polyps, and you're going to be very, it's going to be very difficult to identify purulence coming out of the superior meatus and possibly the middle meatus. In addition to these clinical exam, we often will use radiographic imaging on patients that initially don't respond to medical therapy. And so the modality of choice initially is a CT scan. It gives a very, very good bony anatomy and allows us to actually assess the degree of inflammation or polyps beyond the nasal cavity into the formal sinuses. If any surgery is going to be planned, the CT scan is critical because it gives us all of our bony landmarks or lack of bony landmarks. If there's any atypical signs of sinusitis or polyps, asymmetry, if there's any clinical signs of orbital involvement or epistaxis, or if there's opacification up against the skull base where you don't see a clear distinction between nose and brain, then we will get an MRI to rule out malignancy or encephalocele.
So the principles of managing nasal polyps are based on symptom severity, but also the presence or absence of polyps. There are a number of managed guidelines that have been published. Most recently, the European Position Statement 2020, which we'll discuss in a moment. But the goals of management are to reduce the size of the polyps and give the patients relief, improve their quality of life, and most importantly, to prevent them from coming back. Here's a snippet from the EPOS 2020 guidelines, a central part of the care pathway for chronic rhinosinusitis. In brief, the management of CRS symptoms typically consists of saline nasal sprays or rinses, intranasal corticosteroids, as self-care or primary care, which patients often turn to first. If no improvement is seen after several weeks, most of these patients get referred to secondary or tertiary care centers. And it's important that when we get to this point, that a good history, a full ENT exam, nasoscopy, as well as evaluating for comorbidities is performed. If we find primary or diffuse chronic rhinosinusitis, adequate medical therapy may commence with not only intranasal corticosteroids, but also with reviewing patient compliance and technique, and also considering an upfront course of oral corticosteroids. If patients improve with that type of management, then of course we will continue that therapy. But for patients who do not, this is where an additional workup would be performed. And that would include, as Noam mentioned, a CT scan, allergy skin prick tests, laboratories such as IgE levels and eosinophil counts, and looking for treatable traits, trying to see if we could place this patient into a certain type of mechanism, such as non-type 2 versus type 2. And appropriate medical therapy, if it's exhausted, the next step would be to consider endoscopic sinus surgery or functional endoscopic sinus surgery. For patients who fail all of these measures, despite trying to figure out where they fall on the endotype spectrum, we then would be considering more advanced therapies such as biologicals, aspirin therapy after desensitization in the case of aspirin-exacerbated respiratory disease, perhaps more oral corticosteroid tapers, or a revision surgery or a more complete surgery, which may be best off doing upfront in patients who have diffuse disease. One specific subset of type 2 endotypes is something called allergic fungal rhinosinusitis, which we showed earlier on the MRI scan. This is a subtype of type 2, and these are patients who are usually young and highly atopic. They often have asthma, and they often inhale significant quantities of mold. So they often live in warm and humid climates, and they have positive allergy skin tests for fungi. As we mentioned, they may have extension into the orbit or into the cranium, so we may get our ophthalmological or neurosurgery colleagues involved in these cases. Patients may end up needing oral corticosteroids for prolonged periods of time. They often are treated with a very significantly open surgery, followed by oral corticosteroids, intranasal corticosteroids, and then considering immunotherapy for long-term management. Practitioners should also be aware of the following red flag or alarm symptoms that should prompt immediate referral to a specialist. Patients who have periorbital edema, patients who have displacement of the globe, patients who have difficulty with vision, severe refractory headaches, swelling of the frontal area, signs of infection such as sepsis or meningitis, neurological signs. Unilateral symptoms are often a tip-off that something may be potentially wrong, such as neoplasm, bleeding, crusting, and cachosmia, which is patients who smell fetid odors in their sinuses. These are all potential warning signs that there might be something more than a benign inflammatory polyp present in their cavity. Oral corticosteroids are often used to reduce the size of polyps. Frequently, they're used as initial therapy in a non-operated patient. They can be used post-operatively as well as treatment of exacerbations. But they cannot be used long-term without having unacceptable side effects. And this audience is very well aware of the long-term side effects of oral corticosteroids. So we try to manage primarily with intranasal corticosteroids. And it's important, and Noam will mention it to you when he shows you a little bit about the surgery, that we not only use intranasal corticosteroids, but we use intranasal corticosteroids that actually get to the target of where they need to go. So unfortunately, the routine nasal sprays that are available only hit the inferior turbinate, which is not really where polyps start from. So we like to use, in a specialty setting, enhanced delivery systems or high volume irrigations to try to improve delivery to areas like the middle meatus in a non-operated patient, or if they've been operated on, the frontal recess. These are areas where you tend to see polyps recurring.
So in addition to nasal sprays, one of the big revolutions in the management of rhinologic patients is the use of high volume irrigations. And in this picture, you're seeing a sinus rinse bottle, also known as a neti pot. And the idea behind this is irrigating the nose with a high volume. This is a 1/4 liter of saline. And so this is a mechanical debridement. But in addition to just being a mechanical debridement, we can add in medications such as anti-inflammatories or steroids or antibiotics. And the key here to the success of this is not just the high volume, but it's what's really highlighted in green, which is the retrograde flow. So if you look at the anatomy of the nasal cavity, the turbinates and the sinuses, they're basically built to deflect everything that you inhale in the anterograde fashion, inferiorly and medially. to basically, if you breathe in a nose full of dust, it's going to be bounced down and back, but not up and laterally into the sinuses. However, if you reverse flow and you're driving from the nasopharynx to the nostril, the anatomy actually drives everything superior and laterally. And so that's why these irrigations work so well. They go up one nostril, they get to the choana, they make a U-turn, and they flow back out. And it's that retrograde flow that is incredibly important for delivering medications, not just to the nasal cavity, but it penetrates into the sinuses even without surgery. Now, surgical intervention and the way that it has basically grown over the last 15 years is to truly improve access of the respiratory epithelium out in the lateral recesses and the crevasses of all of the sinuses to this type of irrigation. So we also, as I mentioned, anti-inflammatories, there's also a role for antibiotics, especially if we have culture direction or we have microbes on microbiology that we can treat. And so there's two different forms of antibiotics, a short course, which is basically an exacerbation of CRS, and that's usually culture directed. And there's limited data on long-term low dose use of either macrolides or tetracyclines, which are both anti-infectious and anti-inflammatory. So the role of surgery. In patients that don't have their symptoms resolved based on these medical interventions, we'll escalate it and we'll offer them surgical intervention. And the idea behind the surgery is to not only remove the bulky polyps, but to marsupialize the cavity. And I'll show that in the next slide what I mean, but it's to basically create a wide open cavity such that all of the inflammatory inspissated secretions can drain out, but more importantly, that our irrigations can get in and drain things out. So schematically, on the left side, you can see the sinonasal cavity with the middle turbinate and the ethmoid cavities. And when we operate, what we basically do is we remove all of the small bony partitions such that it's one common cavity, where the superior extent of the dissection is at the skull base, the lateral extent is the medial orbital wall, the medial extent is the middle turbinate, and the inferior extent is the floor. Not only does this surgery remove all the bony partitions, but it works in concert with the natural flow patterns of mucociliary clearance. So if we were just hoping to drain all the mucus by gravity, we would poke a hole in the bottom of the maxillary sinus. But as we started learning about how mucus is actually cleared, that's counterintuitive because the mucus actually is cleared against gravity and then it drops into the nasal cavity. And so the type of surgery that we do now, it's called functional endoscopic sinus surgery because it's working with the function of mucociliary clearance. And so on the right side of the schematic, I'm depicting the mucociliary clearance patterns for the maxillary sinus as well as the frontal sinus. Radiographically, here you can see a sagittal cut and an axial cut through the paranasal sinuses. And what you're seeing is a series of bony partitions coming down from the skull base, coming out laterally from the medial orbital wall, that surgically we go through in succession from anterior to posterior up until the face of the sphenoid. And so at the end of the surgery, what you'll see is a large common cavity, again, where the superior extent is the skull base. On the axial cut, you can see that the lateral extent is the medial orbital wall, and this opens it up into a common cavity. So the ideal post-surgical cavity is demonstrated right here. Wide open cavity, medial orbital wall is skeletonized, skull base is skeletonized, and this patient is very happy. However, you can do the same surgery, and this patient is intermittently symptomatic, where you can see that there still is a degree of inflammation. The mucosa is edematous. And so this patient will go back and forth with having symptoms and feeling good. And then the last scenario is good surgery, but profoundly symptomatic.
So what often leads to failure of sinus surgery is persistence or recurrence of disease based on either inflammation or infection. What we want to ultimately achieve is endotype-specific management. That is managing based on mechanism, based on biomarkers, because each of these polyps have a unique inflammatory signature of cytokines. And if we can find which ones are responsive to which medications and match them up accordingly, we would have better responses. And that's what the ultimate goal is. One example of endotype-specific management is aspirin-exacerbated respiratory disease, or AERD, where it's treated with aspirin desensitization postoperatively to prevent polyp regrowth, and patients continue on long-term aspirin therapy to down-regulate inflammatory mediator release. Polyps are also often enriched with these inflammatory mediators, and again, if we could find biomarkers that will tell us which ones are the predominant ones in an individual patient, then we will be giving personalized therapy. So in summary, CRS with nasal polyps is a complex disease which involves multiple types of immune cells and inflammatory mediators. As we noted, the dichotomous breakdown of clinical phenotypes is not reflective of the underlying endotypic mechanisms that describe the specific inflammation that is often unique to individual patients. The unified airway theory notes that addressing CRS with nasal polyps will have a significant positive effect on the health of the lower airways, because the same inflammatory process which is occurring in the upper airway is also occurring in the lower airway. And finally, if we can get proper endotyping through biomarkers, we will ultimately have specific personalized therapy for CRS with nasal polyps. Thank you.